Alright, we're gonna start with obstetrics. This is the first lecture. This lecture includes basic anatomy review, pregnancy, diagnosis of pregnancy, maternal physiological adaptations to pregnancy, and then the antepartum care. Starting with the basic anatomy review, in this diagram, we basically can see a baby and the placenta attached to it. Placenta has two sides. One is fetal circulation and the other one is maternal circulation. Fetal circulation has arteries which has deoxygenated blood, these two, and then a vein which has oxygenated blood, and this comprises this whole of this thing makes umbilical cord. Then we have amnion, and the fetal part is called as chorion, and the maternal part is called as decidua. Chorion and decidua combines to make a placenta. In the decidua part, in the maternal circulation, we can see that there are endometrial arteries and endometrial veins, and then there are formation of cotyledons because of the fissures inside. So these parts are called as cotyledons. This is a brief overview regarding of placental blood flow. Placenta is a site for fetal nutritive, respiratory, and excretory function. It is a discoid mass composed of fetal, which is chorion frondosum, and maternal decidua basalis tissue, and which is divided by fissures into cotyledons, which are the lobules on the uterine side on the maternal circulation. What does the placenta do? It produces some hormones such as progesterone, placental lactogen, estrogen, relaxin, beta HCG, and infant growth factors. So we are supposed to know all these hormones, and there can be poor implantation, which can lead to spontaneous abortion. Moving forward to pregnancy, how do we diagnose pregnancy? So and the symptoms include, there would be, first thing would be there would be amenorrhea, and then we're gonna have to ask the symptoms regarding nausea, vomiting, breast tenderness, urinary changes, and fatigue. We are also going to ask about the obstetric and gynecological history. In this we're gonna read about gravida. So what is gravidity? Gravida is total number of pregnancies of any gestation. So this is total number of pregnancy. Multiple gestation, one pregnancy. This is the thing, if we are having twins, then that is multiple gestation, but it is it indicates one pregnancy, so that would be just gravida 1. It includes current pregnancy also. So if a lady presents to you who is pregnant and who already has two kids, two pregnancies, who already had two pregnancies, then that would be gravida 3, because she is currently pregnant too. Current pregnancies, abortions, ectopic pregnancies, hereditary moles, any such thing, if it was a pregnancy, then that would be gravidity. Then parity includes TPAL. T is the number of term deliveries. So number of term deliveries would be more than 37 weeks, babies who delivered more than 37 weeks. P is preterm deliveries, 20 to 36 weeks, and then A is aborta, number of abortions, and ectopic pregnancy less than 20 weeks. It could be either induced or spontaneous, so it could be either of them. And then L is the number of living children. That's how we describe the status of pregnancy. Then we have physical signs. Physical signs would include uterine enlargement, breast engorgement, areola darkening, and prominent vascular patterns. We do have a few signs. First of all, we have Goodell's sign, and what do we see in the sign? And there is softening of cervix. So 4 to 6 weeks of gestational age, we have softening of the cervix. Then we have Chadwick's sign, bluish discoloration of the cervix and vagina due to pelvic vasculature engorgement. That happens around 6 weeks of gestational age. So there will be bluish discoloration of the cervix and vagina because the vasculature is engorged in pelvis. So Goodell sign, Chadwick sign, and then we have Hager sign, softening of cervical isthmus. Goodell sign is softening of cervix, and Hager sign is softening of cervical isthmus. And how will we investigate pregnancy? Beta HCG is the go-to thing. We're just gonna measure beta HCG. It is produced by placental trophoblastic cells. Positive in serum 9 days post-conception, positive in urine 28 days after first day of the last menstrual period. So in serum we can detect it earlier, 9 days post-conception, but in urine it is 28 days after the first day of last menstrual period. Regarding the values of beta HCG, the plasma levels of beta HCG usually double every 1 to 2 days, but it peaks around 8 to 12 weeks of gestational age. And this box we could see there's a beta HCG rule of tens. There's 10 international unit at the time of missed menses, so that's the last menstrual period, 10 international units. But at 10 weeks of gestational age, which we read, which is the peak age, it would be 100,000 international units, and at term it would be around 10,000 international units. So there's a peak, and but it is still there till term, but it would be decreased to 10,000 international units. Right, moving forward, if there are the levels of beta HCG are less than expected, we can suggest ectopic pregnancy, abortion, inaccurate dates, or maybe sometimes a normal pregnancy too. But if the levels are greater, then it could be multiple gestation, molar pregnancy, trisomy 21, inaccurate dates, and again it could also be normal pregnancy. It could also indicate a kidney disease, which would be because beta HCG is slowly cleared. That would indicate a kidney disease. Okay, so in investigations we're gonna go for beta HCG, and then moving forward we're also gonna go for ultrasound. Ultrasound, it could be the transvaginal or transabdominal. Transvaginal, 5-week gestational age, we would see a sac, and on 6 week there would be fetal pole visible, right? And 6 to 8 week gestational age, fetal heart activity visible, fetal heart rate visible after 6 weeks on transvaginal ultrasound. So that's the thing to remember, fetal heart rate is visible after 6 weeks on the transvaginal ultrasound. Then we have transabdominal ultrasound, 6 to 8 weeks gestational age, intrauterine pregnancy visible. So around 6 to 8 weeks, intrauterine pregnancy gets visible in transabdominal ultrasound too. I'm just gonna show you transvaginal ultrasound quickly. Here's the transvaginal ultrasound at 5 weeks of gestational age, right? We can see at 5 weeks we could see the sac. The sac is visible, but around 6 weeks fetal pole is also visible. So that was 5 weeks, just the sac is visible. Okay. Alright, so that was pregnancy and how would we diagnose pregnancy. And then we have trimesters. First trimester is 1 to 14 weeks, second is 14 to 28, third is 28 to 42. Normal pregnancy, the normal term is 37 to 42 weeks. Moving forward, maternal physiological adaptations to pregnancy. There are many physiological changes during pregnancy going on in a mommy during pregnancy, right? It includes skin, cardiovascular, hematological, then respiratory, gastrointestinal, genital, urinary, neurological, endocrine, and all of these are physiological. Starting with the skin, increased pigmentation of perineum, areola. Then we also have chloasma, which is pigmentation under the eyes and the bridge of the nose. Then we have linea nigra, which is a midline abdominal pigmentation. Spiderangiomas, palmar erythema due to increased estrogen. This is because of the hormonal imbalance. And then we have stria gravidarum, which is due to the connective tissue changes. So these are the skin changes. Moving forward in the cardiovascular, as now we're just gonna feed the baby too, feed the baby with blood too. So the circulation gets hyperdynamic. It increases the cardiac output, heart rate, and blood volume, but it decreases the blood pressure. How does it decreases blood pressure? Because the pulmonary vascular, there is the resistance in the pulmonary vasculature is decreased, and venous return is also decreased, because as we know that with the growing baby, the uterus starts to enlarge. The enlarging uterus, what it does is, right behind it there is inferior vena cava. it compresses inferior vena cava and all the pelvic veins, which decrease the venous return back to the heart and increase the venous pressure down in the bottom part of our bodies. So that leads to risk of varicose veins, hemorrhoids, and leg edema also. So that's how leg edema is caused in pregnancy, because of decreased venous return and decreased pulmonary vascular resistance. This leads to decreased blood pressure, but the heart rate, cardiac output, and blood volume is increased. Talking about hematological changes, hemodilution is the term which we use because the blood volume is increasing, blood plasma is increasing. So there is a physiological change which we call as hemodilution, which happens in pregnancy. It causes physiological anemia. So basically, hemoglobin, hematocrit, is not decreased, but because of the increase in plasma, there is an apparent decrease in hemoglobin and hematocrit, which is called as physiological anemia. All right, moving forward, there is increased leukocyte count, gestational thrombocytopenia, and hypercoagulable state. The hypercoagulable state increases the risk of DVT and pulmonary embolism also, but it decreases bleeding at delivery. So it has its benefit too, that it decreases delivery. It decreases bleeding at delivery, because that is a pregnancy is a hypercoagulable state. Moving forward, talking about respiratory, so there is increased oxygen consumption, so increased oxygen levels in the body, but that is possible by increased minute ventilation, and which leads to decreased carbon dioxide too. So oxygen in the body overall would be increased, but carbon dioxide would be decreased, and this is what we call as mild respiratory alkalosis. But what happens is this benefits us because of the decreased carbon dioxide. Carbon dioxide gets easier to diffuse across the placenta from fetal to maternal circulation. So it clears out from the fetal circulation because it is decreased in the maternal body, right? So oxygen is higher, carbon dioxide is lower, which is mild respiratory alkalosis, but that helps clearing out carbon dioxide from the baby's body because carbon dioxide diffuses across the placenta. Total lung capacity is decreased, functional residual capacity and residual volume also, but there is no change in vital capacity and forced expiratory volume per second. But we would remember that there is increased minute ventilation, and the diaphragm is also elevated. It appears more like barrel chested, so it is elevated respiratory changes, and there is increased incidence of nasal congestion too. Moving forward, talking about gastrointestinal changes. So there are a few gastrointestinal changes which we would like to mention, starting with GERD, gallstones, constipation, and hemorrhoids, right? What happens is, let me change the color. Okay. Oops. Sorry about that. What happens is because during the pregnancy there is progesterone, right? And progesterone helps relax smooth muscles. It relaxes all the smooth muscles, which leads to decreased sphincter tone and delayed gastric emptying, which would cause the reflux, GERD. And also with that, there is an increase in intra-abdominal pressure because of the baby, because of the gravid uterus, that induces GERD. Other than GERD, there is increased incidence of gallstones too. Guess how? Because progesterone causes the gallbladder stasis, because the smooth muscle relaxes. And the same reason, it decreases the GI motility. So constipation is also there. And then constipation and increased intra-abdominal pressure would lead towards hemorrhoids. So that's the changes in GI. In genitourinary, it increases the urinary frequency. Of course, the gravid uterus is right on top of the bladder, and the total urinary output is also increased because the cardiac output is increased. So that would lead to increased urinary frequency, and there would be increased incidence of UTI and pyelonephritis too, because of progesterone, a smooth muscle relaxing, and there's urinary stasis. There would also be presence of glycosuria. That can be physiological, especially in third trimester, but you have to get checked for gestational diabetes mellitus. Now there's one important thing: ureteric and renal pelvis dilation. So the kidney, the renal pelvis part and the ureters dilate, and right one dilates more than the left one due to progesterone induced smooth muscle relaxation and uterine enlargement. So, progesterone induces smooth muscle relaxation, which would relax the ureters and uterine enlargement too. So, how would we explain uterine enlargement causing ureteric and renal pelvis dilation? So, the uterus lying right here, the gravid uterus, it undergoes some physiological dextro rotation, rotates towards the right side. Let me show you guys. Right here. So dilatation of the uterus, the ureters and renal pelvis, is more prominent on the right than the left, as it has been observed in 80% of pregnant women due to physiological dextrorotation of gravid uterus and engorged right ovarian vein draining into renal vein on the right side. So because of the dextrorotation, there is dextrorotation of the uterus, there is an engorged right ovarian vein. That's how we could see the vasculature. So the right ovarian vein would, the uterus would dextrorotate towards right side, which would put pressure on the right ovarian vein, which would lead to the backup of the blood, backflow of the blood, right? Right ovarian vein draining into renal vein on the right side. So that will cause backflow of the blood. So that induces the dilatation that describes that why the right side's dilatation is more than left side's dilatation. And the smooth muscle relaxation is also one point, right? Increased carbon monoxide and thus increased GFR, increased cardiac output and thus increased GFR leads to decreased creatinine. So cardiac output is increasing and increase of the glomerular filtration rate and decreased creatinine, which is normal in pregnancy, decreased uric acid and BUN. Then moving forward in neurological, there is increased incidence of carpal tunnel syndrome, sciatica, or Bell's palsy. This is because the blood vessels, because of increased cardiac output, the blood vessels tend to swell up, and tight spaces like carpal tunnel syndrome, the blood vessels would swell up and take most of the area, and that would lead to impingement of nerves around them, like median nerve. So increased incidence of carpal tunnel syndrome or sciatica or Bell's palsy, such kinds of impingement are increased because of the blood volume, increase in blood volume. Here is the description: during pregnancy your blood volume doubles. That extra fluid increases pressure and swelling in the blood vessels throughout your body in tight spaces such as carpal tunnel area of the wrist, through which 9 tendons and 1 nerve pass. The swelling can compress the median nerve, which runs to the hand. Okay. Moving forward, we have some endocrinal changes too. Thyroid, moderate enlargement, not clinically detectable, increased basal metabolic rate. There is an increase in total thyroxine and thyroxine binding globulin too, but normal free thyroxine index and TSH levels. Okay, so what happens is, this sentence is the summary. What happens is, the beta HCG and the TSH, these do have some similar looking appearances for the receptors. Let me show you the exact detail. Yes, so when the concentrations of beta HCG are very high, that is more than 200,000, as can be seen in the first trimester of pregnancy, it may actually turn on the thyroid gland and cause it to make extra thyroid hormone, because it pretty much resembles TSH hormone. Right in this box we can read human gonadotrophin HCG is the major hormone produced by the placenta, which is closely related to TSH. HCG can bind to the TSH receptors present in thyroid tissue and act like a weak form of TSH to cause the thyroid to produce and release more thyroxine and triiodothyronine. HCG is the hormone measured in a pregnancy test. Okay, so HCG would lead to increase in thyroxine, right? The HCG would go to the receptors of TSH, and it would force the thyroid to secrete more and more thyroid hormone, which is thyroxine 4 and triiodothyronine, which in turn may turn off the production of TSH from the pituitary itself. So the negative feedback goes there, right? So what happens is HCG and TSH receptors cross reactivity, which would lead to physiological suppression of TSH, because there is an increase in total thyroxine and thyroxine lining globulin, which was because of the receptor cross reactivity. Make sense? Moving forward, adrenals increased maternal cortisol throughout pregnancy, total and free. There is an increase in maternal cortisol right here. So this is the diagram. Secretion of cortisol from adrenal glands is regulated by central negative feedback. In pregnancy, placental CRH. So there is the placental the cortisol releasing hormone stimulates both the maternal pituitary and adrenal. So there is a continuous supply of CRH coming from the placenta, which would induce maternal pituitary and the adrenals to continuously increase the cortisol production. Rising cortisol can also stimulate further placental CRH production. So the cortisol would be keep on rising because of the CRH, and the rising cortisol can also stimulate further placental CRH production. The positive feedback goes back, and it would increase more CRH, which would increase more cortisol, which would increase back to the placenta, positive feedback for more CRH. All right. CRH is the corticotropin releasing hormone coming from the baby. This is why there's an increased maternal cortisol throughout the pregnancy. Okay. Moving forward, calcium. Decreased total maternal calcium due to decreased albumin. Okay, so in pregnancy there is decreased albumin, which would apparently show that there is decreased total maternal calcium. But the useful calcium, the free ionized calcium, the active part of calcium remains the same, because the parathyroid hormone is there, right? It is controlling it. Parathyroid hormone would increase bone resorption, would increase gut absorption, would increase bone turnover, and keep the free ionized calcium normal. But because of the decreased albumin, and decreased albumin is also caused right here. These three lines. During pregnancy, hemodilution causes the serum albumin and hemoglobin to decrease, while the albumin remains low until birth. And as we know that calcium moves around in the blood by getting attached to albumin. This fall in albumin causes the total serum calcium to fall to levels normally associated with symptomatic hypocalcemia. So that is an apparent decrease in the total maternal calcium, but the free ionized calcium, which is the active one, which is what we need, is controlled by parathyroid hormone, and it is normal. That proportion remains the same. So that was some endocrinal changes during the pregnancy. Alrighty, let's start with antepartum care. We're gonna read about preconception counseling, initial prenatal visit, and then a few symptoms, and then subsequent prenatal visits, and then how do we do screening and some diagnostic tools. And yes, That's it. So we're gonna start with the preconception counseling. So baby is not conceived yet. There's preconception counseling. We're talking about 3 to 8 weeks of gestational age, which is a critical period of organogenesis. So early preparation is pretty vital, and the first 3 to 8 weeks are pretty critical too. So we're gonna talk about, in preconception counseling, we talk about some past medical histories, we optimize medical condition, we review the medications. If the medications have any teratogenicity, we alter them, we change them, we switch them, we decrease the dosage, and then we start with some supplementation that might include folic acid, any prenatal vitamins, iron supplementations, which are mostly required in second and third trimester also, but you can also take them earlier if you have some anemia going on. And then talking about all of the lifestyle changes, smoking, alcohol, drug use, you need to quit them. There's zero tolerance for them for baby when you're pregnant. And then domestic violence, occupational risk, poor social support. Talking about medication, the teratogenicity must be adjusted, and then some of the infection screening too, because that's pretty important. We don't want these infections to transmit into our babies. So rubella, hepatitis B, syphilis, pap smear, gonorrhea, chlamydia, HIV, TB testing based on travel and working in healthcare, history of varicella vaccination, parvovirus immunity if exposed to small children, like maybe daycare. So this screening is very important. And then genetic testing too, especially in the high risk group, which include the known carriers, or maybe the women who tend to have recurrent pregnancy loss, or people with family members with some developmental delays or birth anomalies, genetic diseases, or consanguinity. So these would include the high risk groups, and this high risk group must be considered for genetic referrals. They'll go for genetic screening. And the antepartum care could be done by obstetric, family physician, midwife, but the family physicians and midwives can consider consultation for OB if there's any diabetes going on, trial of labor, multiple gestation, malpresentation, antepartum hemorrhage, any of the complications. They would have to go for OB consultation. And the folic acid, which we just read, 0.4 milligrams of folic acid is advised to all patients capable of becoming pregnant. So the ones who are trying to conceive in the preconception counseling, we're going to start them on 0.5 milligrams per day of folic acids, and on prenatal vitamins, or if necessary on iron too. Prenatal genetic screening are voluntary. Okay, starting with the initial prenatal visit. Usually within the 8 to 12 weeks of the first day of last menstrual period, or it could be earlier if there's any extremes of maternal age, or any bleeding, any extreme nausea, or any risk factor present. So they can come to you earlier, but initial prenatal visit is usually around 8 to 12 weeks of the first day of your last menstrual period. And in this visit, what we're gonna do, we're gonna start with the history. In the history, first thing first, we're just gonna look for first of all, of course, we're gonna confirm the pregnancy, as it is the initial prenatal visit, by investigating by beta HCG. And then we're gonna look for gestational age by dates. And then we do have this formula, Nagel's rule. What we do is we ask them for the first day of last menstrual period, we add a year, add 7 days, and then subtract 3 months. Then we do have some estimated date of delivery, but it is not reliable if you have irregular menstrual cycles. With that, in the initial prenatal visit, we also go for dating ultrasound. It should also be offered to all women. And what we say is the estimated date of delivery by The first trimester ultrasound after 7 weeks is more reliable than the one we calculate with the formula. Okay, so with that T1 ultrasound, we can also look for estimated date of delivery. We can ask them about history of their pregnancy, any change, any complications, bleedings, or anything, and then the previous histories, past medical, surgical, gynecological history, medications, family history, social history, and we are also going to screen for intimate partner violence. Ask every woman about abuse, not just those whose situations raise suspicion of abuse, and ask as early as possible in pregnancy. So we have to ask about intimate partner violence, and that could be indicated, if you have any if you see any bruising on the lady, and if there's any improbable injury, depression, late prenatal care, they just present in second or third trimester, they're not coming in the first trimester, and they miss their prenatal visits or appointments, or short they cancel them. So we have to screen for intimate partner violence. And then in physical exam, we're gonna do the baseline patient information. Blood pressure and weight are important, and BMI is also pretty important. In blood work, CBC, blood group, and RH status, which is very important. Antibody screen and infection screen as per preconception counseling. So we're gonna go for blood group, RH status, antibody screen, and infectious screening. And we are also gonna send urine routine and microscopic midstream urine culture and sensitivity to screen for any bacteriuria and proteinuria. We are also going to go for pelvic exam, pap smear, and we might also like to go, and pap smear would be according to the provincial guidelines. We might also like to go with cervical or urine PCR for Neisseria gonorrhoeae and chlamydia trachomatis. All right. So that's a little bit overview of your first visit. What do you expect in your first visit, right? And in history of previous pregnancy, what they're gonna ask you, we are gonna ask the pregnant ladies about GTPL, which we already read. What year was your previous pregnancy? What sex? How much weight was it? What was the gestational age, mode of delivery, length of labor, any complication during that delivery? So these are a few important questions. We also have this little box in which they tell us that the estimated date of delivery determination. There are many ways we can determine estimated date of delivery. We can estimate it by the last menstrual period. If menses are regular and the patient remembers, well and good, but if no, then you have to go with the first trimester ultrasound. And if there is any in vitro fertilization, we have to go by the embryo age and date of transfer. But the thing is, first trimester ultrasound up to almost 14 weeks gestational age is most accurate method of establishing gestational age. So first ultrasound is the most accurate method, and then if there are changes, you have to report and document and discuss with the patient moving forward. If you find any changes because of some inaccurate dates or whatever reasons, we find any changes in the estimated date of delivery, we have to inform the patient and discuss. Pregnancy without ultrasound confirming or revised the EDD prior to 22 weeks plus 7 weeks, which is 23 weeks gestational age, is considered suboptimally dated. So we have to review the EDD in the second trimester also, otherwise it would be suboptimally dated. Moving forward, we do have some nausea and vomiting and hyperemesis gravidarum. Nausea and vomiting affects pretty much majority of the pregnant woman, 50 to 90%. That would be because of hormonal changes. It is often limited to first trimester, but it may persist beyond it. And what we have to do is we have to make sure that nausea and vomiting is not being triggered by any other thing. We have to rule out other causes. We have to follow up the lady with frequently checking their weight, checking their level of hydration, and test their urine for ketones. So we just have to keep any pathological causes ruled out. We can also suggest them some non-pharmacological management. We can tell them to have frequent but smaller meals. Bland, dry, salty are better tolerated. We have to replenish their electrolytes by electrolyte oral solutions like Gatorade. We can also ask them to increase your sleep, take some rest. We can also ask them to have some ginger, which might relieve with nausea. And then acupuncture, acupressure, and mindfulness based cognitive therapies. But we do have pharmacological options too, and the first line goes with pyridoxine B6 monotherapy, or diclectin, which is pyridoxine and an antiemetic combination, which is doxylamine. And this combination, we have to take 4 pills per day per oral, one every morning, one with lunch, and 2 at night. But maximum of 8 tablets per day you can take for diclectin, right? First line is pyridoxine. Then we can also have H1 receptor antagonist, I believe the diphenhydramine, and then metoclopramide, phenothiazines can also be an adjunctive therapy for severe. We can also take some onset, ondansetron, and then consider some acid reducing medications as adjunctive therapy also. If there is severe and or refractory, we can consider home care with IV fluids and parenteral antibiotics, and we can also consider hospitalization. Moving forward, hyperemesis gravidarum, it affects 1% of pregnancies. If the nausea vomiting gets intractable, then we call it as hyperemesis gravidarum. It also usually presents in first trimester, but then it diminishes, but it can persist throughout pregnancy. It is multifactorial, mostly because of hormonal or immunological or psychological. How will you investigate? You just have to rule out some systemic causes. There's nothing systemic or pathological going on. You have to also order CBC electrolytes, spun, creatinine, and LFTs, urinalysis, and ultrasound. Make sure the electrolytes are normal, kidneys are working good, liver is working good. In management of hyperemesis gravidarum, we can go with thiamine supplementation. These may be indicated. Non-pharmacological options are similar to the nausea and vomiting, almost similar. You could try all of those, but pharmacological options again includes diclectin, doxylamine, pyridoxine, dibenhydrinate, other adjuncts like metoclopramide, ondansetron, and if severe, you have to admit them to hospital so that they are NPO. They can take small frequent meals initially, but you have to correct the hypovolemia, electrolyte disturbance, and ketosis. You can also make them TPN if it is very severe. Complications in hyperemesis gravidarum includes maternal complications and fetal too. In maternal, because of the vomiting, there's dehydration, electrolyte and acid-base imbalance disturbances. They can also call Mallory-Weiss tears in your esophagus, Wernicke encephalopathy too. If protracted course, if it's not controllable, then it could lead to Wernicke encephalopathy because of the subsequent electrolyte and thiamine deficiency. And it could also lead to death. And on the fetal side, usually none, but if the lady has started to lose weight, and we know that women losing more than 5% of the pre-pregnancy weight can lead to intrauterine growth restriction, and they have 15% more chances of having that. Okay, moving forward, in the subsequent prenatal visits, what we're gonna do is timing. First one, we said that would be around 8 to 12 weeks, but the question is, when would you want the patient to see you next? So if there is no complication, then until 30 weeks of gestation, we see them every 4 to 6 weeks, which is like every month. But from 30 to 36 weeks, we see them every 2 to 3 weeks. We see them more often, and after 36 weeks, we would like to see them every 1 to 2 weeks. As the critical time comes, so until delivery after 36 weeks, we see them every week. And what do we assess at every visit? So at every visit, we're just gonna confirm the estimated gestational age, talk about history, fetal monitoring, vaginal bleeding, leaking, cramping, any questions, any concerns. ABCD is a formula. It had E too. So A is activity of baby. B, any bleeding by any chance. C, any contractions you had, any cramping you had. D, any discharge you saw. It might be bloody, it might be some other color. And E is the estimated date of delivery, which is the estimated gestational age, which might be related to the estimated gestational age, which we just mentioned here. And in the physical exam, you have to see the blood pressure, weight gain, symphysis, fundal height. So let's talk about symphysis, fundal height first. So that's just to learn 12-week gestation, 16-week gestation, 20 weeks gestation. So at 12 weeks it is at the pubic symphysis, and at 16 weeks the fundus of uterus is halfway between the umbilicus and symphysis. Symphysis, pubic symphysis, and at 20 weeks it's right at the umbilicus. So here's the uterus apparently, and this is 12 weeks, and then this is 16 weeks, and then this is 20 weeks. And after 20 weeks the height should be within 2 centimeter of the gestational age. So if it is 22, so it should be 2 centimeter above. So 2 centimeters, SFH would be within 2 centimeters of the gestational age. If gestational age 22, so it would be 24. The height would be if SFH should be within 2 centimeters of gestational age. So if gestation is 22, so it should be within 2 centimeters. So that would be 24. Okay, moving forward, if SFH is less than the symphysis fundal height is less than the dates, these dates, then of course the baby is growing smaller, or maybe there's any other problem. There's fetal demise, there's oligohydramnios, there's early engagement, baby's engaged, or there's transverse lie, or simply there's date miscalculation. But if it is more, of course, date miscalculation, but maybe multiple gestation, polyhydramnios, large for gestational age, and diabetes, or maybe there are fibroids. So we have to make sure to rule these out too. Okay, so the physical exam would include this, measuring the height, measuring blood pressure, weight gain, and we can also do the Leopold's maneuver in 3rd trimester. Right here in 3rd trimester, around 30 to 32 weeks of gestational age, we do this maneuver. It has 4 steps. In the first maneuver, we're gonna determine which fetal part is lying furthest away from the pelvic inlet. Right here, which fetal part is that? Then in second maneuver, we're gonna determine the location of fetal back. And third, we are going to determine which fetal part is lying right above the pelvic inlet. And in fourth, we're going to find where is the fetal brow. So we are going to locate that. So that's Leopold's maneuver, which we do around 30 to 32 weeks of gestational age, 3rd trimester. It helps us determine what is the lie of the baby, what is the position, and what would be the presentation of fetus. Okay. Moving forward, at every visit, we can also send some investigations, urinalysis for proteinuria, only in high-risk women, if patient is hypertensive. So we have to look for proteinuria to follow up with preeclampsia. And then fetal heart rate tracing too. Fetal heart rate monitoring starting at 10 to 12 weeks using Doppler ultrasound. So at 10 to 12 weeks, we can start using Doppler ultrasound. And in the beginning, we read fetal heart rate is visible in the transabdominal ultrasound around 6 weeks. So in Doppler ultrasound, it would be 10 to 12 weeks. Yes, that's pretty much it till here. Now we're going to talk about prenatal screening and some diagnostic testing. Talking about prenatal screening and diagnostic testing, the screening must be done with informed consent from the patient. There are a few diseases which must be screened in a high-risk population. Here's the table: thalassemia, sickle cell, cystic fibrosis, Tay Sachs disease, Fragile X syndrome. These are some populations in which there's more prevalence of these diseases, and they have more tendency to acquire these diseases. So we do have some screening tests in front of them written too. You can just have a quick look. In thalassemia, we're gonna go for CBC, hemoglobin electrophoresis, or high performance liquid chromatography. Similar for sickle cells and cystic fibrosis, we're gonna go for CFTR gene DNA analysis. And in Tay Sachs disease, we're gonna go for DNA analysis of hexa gene. So cystic fibrosis has CFTR gene. Tay Sachs disease has hexa gene, and then we have Fragile X syndrome. In there's DNA analysis for FMR1 gene. Okay, moving forward, this table is pretty important. It pretty much summarizes gestation-dependent screening investigations. How are we gonna screen, and what investigations we're gonna do? This table I have tried to color code to make it kind of easy. So first of all, we're gonna look into ultrasounds. We can see over here. Okay, right here we have some ultrasounds. 3 ultrasounds. First one would be around 8 to 12 weeks, the dating ultrasound. Second one would be 11 to 14 weeks, in which we have to look for the nuchal translucency. And the third one would be around 18 to 20 weeks for fetal size, anatomy assessment, and placental location. So these 3 are the ultrasounds. But other than these ultrasounds, we can also do any earlier or subsequent ultrasound can be performed when medically indicated. Let me give you a quick look of ultrasound screening in this paragraph too. So first one is 8 to 12 weeks gestational age. That is the dating ultrasound. That is most accurate form of pregnancy dating and getting the EDD out of it. It should be based on first trimester ultrasound. And we also measure crown rump length in this one. Moving forward, the second one would be 11 to 14 weeks for the nuchal translucency. We measure the amount of fluid behind the neck of the fetus. And this is an early screen for trisomy 21, and it also determines some cardiac anomalies also. The nuchal translucency measurement is necessary for the first trimester screening. So it happens in 11 to 14 weeks. And then 18 to 20 weeks of gestational age, we do a growth and anatomy ultrasound, in which we described right here that we look for fetal size, anatomy assessment, and placental location. So that is growth and anatomy ultrasound. Okay, so this was a quick look of ultrasounds. First of all, starting with the table, the 8 to 12 weeks investigation, in that one we just read in the prenatal visit, the initial prenatal visit. It includes dating ultrasound, possible pap smear based upon your province guidelines, then chlamydia, gonorrhea testing, urine culture insensitivity, HIV, VDRL, hepatitis B surface antigen, rubella, parvovirus, and varicella, CBC, blood group, and screening also. So these investigations, we just had a pretty detailed look in the initial prenatal visit right here. Okay, so this one is the initial prenatal visit, the first paragraph, which is 8 to 12 weeks. Moving forward, more than 10 weeks, we do a non-invasive prenatal testing, NIPT, in which we measure cell-free fetal DNA in maternal circulation. So this is non-invasive test. If we find anything positive in the dating ultrasound, or if we have any kind of indication because of our family history, or any indication which might lead to any kind of suspicion of any cardiac anomaly or any congenital problems, we're going to go for non-invasive prenatal testing, NIPT. It analyzes, what it does is, it is totally non-invasive. We're not going to go and disturb the baby in the amniotic fluid. We're going to go for maternal blood and analyze the maternal blood for circulating cell-free fetal DNA at 10 weeks of gestational and onwards, right? And what we can do is we can accurately find out any changes, because we would find cell-free fetal DNA, right? Fetal DNA is all we need, but there are some disadvantages to it too. Quickly just telling you some advantages: that it has increased accuracy, but and also earlier timing with results. It is available in 1 to 2 weeks, and parents can potentially have a quick CVS, because CVS is the earlier diagnostic test which we could do around 10 to 12 weeks, and then we can, you know, go for diagnosis if as compared to amniocentesis, which we would have to wait till 15 weeks. So parents can potentially have a CVS earlier for early diagnosis. That's the advantage of NIPT. But the disadvantage is it does not help us to look for open neural tube defects, and it is not covered by most provincial health insurance systems. It needs to confirm with invasive testing. So it is just a screening test, right? It is a screening test. It's not a diagnostic test. So we have to confirm it with some diagnostic test, and those includes maybe CVS, maybe amniocentesis, right? And it is also affected by, you know, we have to find sufficient fetal fraction in maternal blood. What if there's not sufficient fetal fraction? What if there's no fetal cell-free DNA in our sample? So there have to be sufficient fetal fraction, which is usually affected by gestational age or maybe maternal obesity and the presence of chromosome aneuploidy in either the placenta or the mother. So it is not that specific. It does not test for all aneuploidies also, and give no results in 1 to 5% of cases because of the insufficient fetal fraction, and more common with elevated BMI. So maternal obesity might be a reason for inaccurate NIPT results, but NIPT would be done around more than 10 weeks, and it is non-invasive. All right. And then we're gonna look into the green codes. The green codes over here, 10 to 12 weeks and 15 to 16, 2-term, are the two diagnostic tests: chorionic villus sampling or amniocentesis. We're gonna quickly read about them. First one is amniocentesis. So amniocentesis is one of the diagnostic testing. Right here, I'm gonna quickly show you. Right here is amniocentesis. So this is the needle which is guided under the ultrasound, and it draws amniotic fluid out of the uterine cavity. Okay, so what happens is ultrasound guided transabdominal extraction of amniotic fluid performed around 15 weeks of gestational age. When is it indicated? If we identify any genetic or chromosomal abnormalities as per indications above, any positive NIPT testing, any positive maternal serum screening testing, or that I would that I would explain next, the maternal serum markers we test, and then we can also use that for assessment of fetal lung maturity in 3rd trimester. Amniocentesis can be used because we just draw some amniotic fluid, so we can look into lecithin to cephalin, or maybe I'm not sure, lecithin to the S protein ratio. If more than 2:1, RDS is less likely to occur, so there will be no respiratory distress syndrome. So it is also used in that to look for fetal lung maturity in 3rd trimester. Advantages: it can screen open neural tube defects. In women more than 35 years, risk of chromosomal anomaly is greater than the risk of miscarriage from the procedure. Although there is a risk of miscarriage, but Of course, you know, in extremes of age there are more risk of chromosomal anomalies, so it is better to get this done, and it is more accurate genetic testing than CVS. Right here, compared to CVS, amniocentesis has a higher accuracy of prenatal cytogenic diagnosis and lower risk of spontaneous abortion. So amniocentesis is better off than CVS, but there are some disadvantages. Procedure related pregnancy loss, results take around 14 to 28 days, but we do have some preliminary results. Moving forward, talking about chorionic villus sampling. We read that in placenta, the fetal part is called as chorion. So what we do is we take a little bit of sample biopsy of the fetal derived chorion using a transabdominal needle or a transcervical catheter at 10 to 12 weeks. CVS is done earlier. So we just take fetal derived chorion biopsy. It enables pregnancy to be terminated earlier than with amniocentesis. So we do it at 10 to 12 weeks. If we make a early diagnosis, if the parents want, they can able to terminate their pregnancy earlier. And the rapid karyotyping and biochemical assay within 48 hours is also available, but the disadvantage is that it does not help you screen for open neural tube defects, and there are some 1% risk of procedure related pregnancy loss also. Okay, moving forward, talking about neural tube defects, which we can detect from the using in the amniocentesis. What are the risk factors? What would be the indication for going for screening so bad that how would we know what are the risk factors? So it could be genetic. There might be family history of neural tube defects. Risk of having second child with neural tube defect is approximately increased 2 to 5%. And then consanguinity, and then chromosomal problems. So G would be genetic, R would be race, high risk in Europeans and threefold higher in Hispanics. And then I would be insufficient vitamins like zinc and folate. So vitamins are insufficient, which might lead to neural tube defects. And then M is maternal chronic disease, like maybe diabetes, which might lead to neural tube defects. And then maternal use of anti-epileptic drugs, which would be teratogenic and which would lead to open neural tube defects. But the general population is like 0.1% risk of NTD. These are the risk factors of NTD. In such cases, we have to screen very critically, right? So these are the two diagnostic testing which was coded in green color: CVS and amniocentesis. So we talked about 3 ultrasounds, we talked about the 2 diagnostic testing, and we talked about NIPT, which is a screening test too. Now we do have something to talk about IPS, which is integrated prenatal screening. It has 2 parts. This is coded blue in this chart for me: IPS part 1 and IPS part 2. And IPS part 1, so this is basically blood tests to test for markers in blood. Part 1 is enhanced first trimester screening, and part 2 is maternal serum screening. What we do is we draw blood from the mommy and we measure beta HCG, PAP-A, placental growth factor, and maternal serum alpha fetoprotein. So that's enhanced. If it is enhanced FTS, then placental growth factor and MS, maternal serum alpha fetoprotein, is also measured. But if it's not enhanced FTS, if it says IPS part 1, we're gonna go for integrated part includes the ultrasound. So we're gonna go for ultrasound, beta HCG, and PAP-A. But IPS part 2, which is maternal serum screening, it includes maternal serum alpha fetoprotein, beta HCG, and conjugated estrogen. This is usually the screen, which is called as triple screen, but it also might include inhibin A, measurement of inhibin A, which would make it quadruple screen. So IPS part 2 is maternal serum screen, which could be either triple screen or quadruple screen. So these 2 are the screening methods, which has a comparison right here. This table shows a comparison between the enhanced first trimester screening, maternal serum screening, and integrated prenatal screening. Basically, integrated prenatal screening, as you can see, includes both EFTS and MSS, which includes inhibin A, quadruple. So it includes both of these, the first one and the second one. This one's in the first trimester. This one happens to happen in second trimester maternal serum screening. Okay. We can also quickly look into EFTS would risk estimate for Down syndrome and trisomy 18, and MSS would tell us risk estimate for open neural tube defects also. So the maternal serum alpha fetoprotein, it is sensitive for open neural tube defects. So we can estimate that too in MSS, but trisomy 21 and trisomy 18 can also be assessed. And a patient with positive screen should be offered any of these screening, FTS, MSS, or IPS. Any screening, if patients with positive screen, should be offered ultrasound. So we're gonna go for ultrasound, and or so we have to add either amniocentesis or NIPT, depending upon how positive the screen is. If it is like very high values, very indicative, then we directly go for diagnostic, which is amniocentesis. But if we're still suspicious, we're not gonna go and directly go for invasive test. We're gonna go for non-invasive test first, but ultrasound is there. So patient with any of the positive screening, we will go for ultrasound and screening test, another screening test after it, right? And in twins, EFTS, MSS, IPS are not applicable. We have to screen with nuchal translucency, NIPT for chromosomal abnormalities, and MSAFP for open maternal serum alpha fetoprotein for open neural tube defects. So we do these three things in twins. We don't really go for these serum screenings. We just go for nuchal translucency, non-invasive prenatal testing, and maternal serum alpha fetoprotein for open neural tube defects. Alrighty, moving forward, I mentioned this box earlier. Second trimester ultrasound, 18 to 22 weeks. We help us determine this one right here: fetal size, anatomy assessment, and placental location. I mentioned it is called as growth and anatomy scan. So in this 18 to 22 weeks, we also look for number of fetuses, gestational age, location of placenta, fetal anomalies, and differentials of increased maternal serum alpha fetoprotein may be incorrect. Gestational age, more than one fetus might also increase our alpha fetoprotein. If it could be either more than one fetus, it could be the fetal loss, and the one which we read already, open neural tube defects, abdominal wall defects like omphalocele, that might also lead towards increased maternal serum alpha fetoprotein. Okay, so we did the blue coded 2. Moving forward, 18 to 20 weeks to term, we have to do fetal monitoring, quickening, which will come in fetal surveillance in our next topic. And then we have two important things: 24 to 28 weeks, we have to screen for gestational diabetes, oral glucose tolerance test, and in 35 to 37 weeks, we have to go for group B streptococcus screening, GBS screening, and depending on that, we would have to go for antibiotic or whatnot. So these two are some important dates. And then we also go for, in 28 weeks of gestational age, if mommy is Rh negative woman, then we also go for ROGAM, which is Rh immunoglobulin. I'm gonna go into its detail right next to this paragraph. So that's the end of this, but we're gonna do the ROGAM thing right after it. Just wanted to let you know about 6-week postpartum. We have to discuss contraception, menses, breastfeeding, depression, mental health support, and in physical exam we have to do all the physical exam too, pap smear too, and wound assessment. Right here is an important thing. Can consider ordering alpha-fetoprotein to screen for open neural tube defects in women with BMI more than 40. So we know MSA alpha-fetoprotein is raised, then we can suspect open neural tube defects. We did ultrasound, we did NIPT, we did the comparison, then the 2 diagnostic testings, amniocentesis and chorionic villus sampling, that the indications are higher age, extreme age in mommies, risk factor in current pregnancy, any abnormal ultrasound, any abnormal prenatal screenings, and any of the family history. We read about amniocentesis, we read about chorionic villus sampling. Now we have this last topic which we were just talking about for the administration of ROGAM in RH negative women at 28 weeks of gestational age. Why would we have to do it? I had a few diagrams more to show. Yeah, here's the chorionic villus sampling. Right here we can see it's such a pretty diagram. So that is chorion, which is the fetal side, and those are the villi in it, in placenta. So we take a little piece out of it, from the sample out of it, which we send for the biopsy, which we send for looking into it for any cardiac anomalies or any aneuploidies, any chromosomal abnormalities. Okay, we saw amniocentesis. Okay, so what is the definition? We're talking about isoimmunization screening now. Isoimmunization, what does that mean? What happens is, if mommy, I have a diagram for that too. Let me show you. Yeah, so if mommy is RH negative and baby is RH positive, through the placenta, RH positive antigens would cross into mommy's circulation. Mommy would produce RH antibodies, anti-RH antibodies against the baby, and that would harm the second pregnancy even more. Okay, so what happens is, antibodies produced against a specific RBC antigen as a result of antigenic stimulation with RBC of another individual, even if it's your own baby, but that's another individual, and they are positive, you're negative. So if there's antigenic stimulation, your body would produce antibodies against it. And of course, as the placenta, the fetal cells had, fetal cells, of course, they cross the placenta. That's how there was antigenic stimulation and there was production of antibodies. Similarly, if the antibodies cross the placenta and get back to the baby, there would be hemolysis, right? There would be fetal anemia. So etiology: maternal fetal circulation normally separated by placental barrier, but sensitization can affect the current pregnancy, but more commonly the future pregnancies. So we have to give anti-RH antibody. What happens is, and what anti-RH antibody does, it already calms down the antigens entering the maternal circulation and does not let maternal circulation trigger to be producing more and more antibodies against it. So anti-RH antibody produced by a sensitized RH negative mother can lead to fetal hemolytic anemia. Risk of isoimmunization of an RH negative mother with an RH positive is 16%. And the routes might be blood transfusion, fetal maternal transplacental hemorrhage, invasive procedures, abortion, delivery, or trauma. But if we see a positive titer, more than 1:16, indicates an increased risk of course, fetal hemolytic anemia that would be increased. How do we investigate this isoimmunization? We go for an indirect Coombs test. At first visit for blood group, RH status, and antibodies. So at first visit, you're going to go for blood group, RH status, and antibodies. Then we have Kleehar-Betke test. What it does is, it is used to determine extent of feto-maternal hemorrhage. It estimates the volume of fetal blood volume that entered maternal circulation. So it helps us, have an estimate that how much blood has already entered, how much fetal blood has entered the maternal circulation. Kleehar-Betke test. And why we need to measure this? Because we have to administer ROGAM in mommy's body. ROGAM is the anti-RH antibody. So that is the amount, the dose of ROGAM depends upon the amount of fetal blood entering the maternal circulation. So the standard dose of 300 micrograms of ROGAM is sufficient for 30 milliliters. So in general, we do give 300 micrograms at 28 weeks, but we have to give additional 10 micrograms for every milliliter over 30 milliliters. So with Kleehar-Betke test, we measure how much fetal blood volume has entered, and then according to that, we give the dosage of ROGAM. So the investigation for isoimmunization would be indirect Coombs test, Kleehar-Betke, detailed ultrasound. We can also go for middle cerebral artery Doppler. That would help us to look for the degree of fetal anemia. We can also measure bilirubin by serial amniocentesis to assess the hemolysis. We can also go for chordosynthesis for fetal hemoglobin, but it should be cautiously used. This is how we do the chordosynthesis. We aspire blood out of the umbilical cord. That's how we do chordosynthesis. Okay, chordosynthesis can also be used to investigate. And how would we do prophylaxis? Exogenous Rh IgG would be given, ROGAM. It binds to the Rh antigens and prevents them from contacting the maternal immune system, and soothes them before they are triggered to make their own antibodies. But these are IgG, don't forget these are IgG. ROGAM is given to all Rh negative and antibody screen negative women in the following scenarios. So there are two scenarios. I have made 2 stars. There can be Rh negative women, but their antibody screen is also negative, right? They don't have antibodies yet. But there could be another case if they are Rh negative, but the antibody screen is positive. They already have antibodies in them, right? What we do in that case? So first we'll read about antibody screen negative. They are Rh negative, no antibodies in them, but when we give them routinely at 28 weeks, which we read in that table. It will protect them for 12 weeks. Then we give within 72 hours of the birth in of Rh positive fetus. Any invasive procedure, if you're gonna give ROGAM. Ectopic pregnancy, abortion, antepartum hemorrhage, trauma. Question arises like, why an abortion baby is not there anymore? Why an ectopic pregnancy? Because entering of fetal blood in the maternal blood would lead to production of antibodies, which would lead problem for the next baby. So we have to give them ROGAM in ectopic pregnancy, in abortion, in antepartum hemorrhage, and trauma. Moving forward, if she's Rh negative but AB screen antibodies are already there, now what? Then we just have to do a close follow-up, serial monthly titers, ultrasound, serial amniocentesis as needed. Now ROGAM has no benefit as the B cells are already sensitized. B cells sensitized antibodies already in the circulation, so ROGAM wouldn't work now because they are antibody positive already. Just have to follow up closely. Okay, how do we treat them? Falling biliary pigment warrants no intervention. That means it is getting better. Intrauterine transfusion between 18 to 35 weeks of gestational age of O negative packed RBCs may be required for severely affected fetus. So we inject and transfuse O negative packed RBCs for fetuses, or we do early delivery of the fetus for exchange transfusion following 35 weeks gestational age. So if it is 18 to 35 weeks, we do intrauterine transfusion. Because of hemolysis, that wouldn't be sufficient, so we transfuse intrauterine, or after 35 weeks we need to transfuse, so we just do early delivery of the fetus. And complications might include so anti-Rh IgG can cross placenta and cause fetal RBC hemolysis, as we read already, because babies RH positive, and these antibodies will go and do hemolysis, and hemolysis would lead to anemia, which would lead to congestive heart failure, edema, and ascites. There are severe cases. Hydrops fetalis. What happens in hydrops fetalis? There's edema in at least 2 fetal compartments due to fetal heart failure secondary to anemia. So there would be edema in at least 2 fetal compartments, or there would be erythroblastosis fetalis, moderate to severe immune-mediated hemolytic anemia. So we have here hydrops fetalis. There is swollen liver, severe abdominal swelling. So more than 2 compartments, there would be swelling. Okay, because of hemolysis, there is anemia and there's congestive heart failure. And then in erythroblastosis fetalis, as I shared already, the antibodies would attack the baby. Moderate to severe immune mediated hemolytic anemia, that would be immune mediated. And in hydrops fetalis, because of RBC hemolysis, it would lead to anemia and then CHF. Okay, so this was isoimmunization, and in which RhoGAM was pretty important, and that we read in this table that RhoGAM is given around when RhIgG for all the Rh negative women in around 28 weeks. That's all for the first lecture of obstetrics. We're gonna do fetal surveillance tomorrow. That's a little topic which is left for tomorrow. We completed till here. Just a quick question regarding, we did these physiological changes during pregnancy, so we have a quick question regarding that right here. 32-year-old woman is evaluated at her 32nd week of pregnancy. Laboratory results are as follows: pH, oxygen high, carbon dioxide low, bicarb, hemoglobin, white blood cells, sodium, potassium, chloride, BUN, creatinine. Which of the following best explain this patient's acid-base status? That is normal pregnancy. Pregnancy causes many normal physiological changes. Progesterone rises significantly during the first trimester and changes the homeostatic set points in the medullary respiratory centers of the brain. Progesterone can directly stimulate the respiratory center to increase ventilation. Medulla is thought to become more sensitive to changes in the partial pressure of carbon dioxide and responds with exaggerated respiratory effort. So what happens is, normal hyperventilation of pregnancy is characterized by increased tidal volume, increased minute ventilation, and chronic respiratory alkalosis. Increased minute ventilation increases oxygen to meet the metabolic demands of pregnancy, of course, and the respiratory alkalosis usually lowers carbon dioxide. As the progesterone concentration increases during the later stages of pregnancy, there is increased pH too, 7.4 to 7.45, with some metabolic compensation with decreased serum bicarbonate as seen in this patient. So progesterone concentration would increase and would lead to increased oxygen, decreased carbon dioxide, pH would increase, and some metabolic compensation which would decrease bicarb. And that's all normal. That is normal pregnancy. These are the physiological changes which we talked about right here in the respiratory part. 2 more questions. A 36-year-old woman, gravida 2 para 1, at 9 weeks gestation comes to the office to initiate prenatal care. Patient's first pregnancy ended in a vaginal delivery after an induction for preeclampsia at 38 weeks gestation. After her first pregnancy, the patient had orthopedic surgery for an ankle fracture that was complicated by a DVT, which was treated with anticoagulation. So she had DVT after her first pregnancy. She has otherwise been healthy and active. She is taking prenatal vitamins and no other medications. Blood pressure is 120/70. Weight is 55 kilograms. Pelvic examination shows an enlarged, non-tender uterus with no adnexal masses. Due to the patient's history of preeclampsia and DVT, a complete blood count, basic metabolic panel, hepatic functional panel, thrombophilia panel, and urinalysis and urine culture are ordered. Which of the following changes may be seen in a healthy pregnant patient when compared to a pre-pregnant state? So basically this scenario is not really linked to the question. We are just asking which of the following changes may be seen in a healthy pregnant patient when compared to the pre-pregnant state. So as we read the physiological changes and during pregnancy, these are some options: decreased serum creatinine, decreased serum fibrinogen, decreased urine protein, increased hemoglobin level, increased platelets, increased protein S activity, increased transaminases. So that would be decreased serum creatinine, as we read, because of the increased cardiac output. GFR also increases, which would increase the clearance, and serum creatinine would be decreased. So that's the correct answer. Renal and urinary changes in normal pregnancy. Renal blood flow increases, GFR increases, renal basement membrane permeability also increases. And laboratory findings would show decreased BUN, decreased uric acid, decreased creatinine. Increased renal protein excretion. So in normal pregnancy, GFR, renal blood flow increases, serum blood urea, nitrogen, and creatinine become decreased. Renal function increases gradually in the first trimester and reaches 40 to 50% above non-pregnant state, after which it remains unchanged until term. Renal basement membrane permeability is also increased in pregnancy. Due to the increase in renal function during pregnancy, patients on medications that are renally excreted, like gabapentin, require close monitoring and dose adjustments as necessary because there's increase in renal function. In addition, a serum creatinine of 1.2 may be the upper limit of normal in a non-pregnant woman, but it is considered renal insufficiency in a pregnant woman because the normal is decreased. So in a non-pregnant woman, even though 1.2 is the upper limit, but in a pregnant woman, that is renal insufficiency. Okay. Moving forward, the fibrinogen of choice is BNF, decreased serum fibrinogen, and it says increased protein S activity, which is the complete opposite. Maternal adaptations has some homeostatic fibrinolytic proteins, changes in them which contribute to hypercoagulable state in pregnancy and increased risk of thromboembolic diseases when compared to pre-pregnant state. These changes included, so basically protein S activity is decreased and fibrinogen is increased, and an increase in resistance to activated protein C. The hypercoagulable state is likely a mechanism to minimize bleeding during delivery. So even though it causes some risk factors towards DVT and the hypercoagulable states towards clotting, but it also minimizes bleeding during delivery. So decreased in protein S activity. So not increased, the protein S activity decreases, and serum fibrinogen increases in pregnancy. In non-pregnant patients, renal excretion more than 150 milligrams of protein is considered abnormal in non-pregnant. However, in pregnant, due to the increase in GFR, renal basement permeability also increases, and urine excretion of more than 300 milligrams of protein is considered abnormal. So 150 to 300 would be normal in pregnant ladies. So urine dipstick finding of trace plus 1 protein is normal in pregnancy, okay, because the permeability increases. During pregnancy, the plasma volume increases more than the red cell mass, causing a mild decrease in hemoglobin concentration, which we call as hemodilution. Dilutional anemia protects the mother in case of postpartum hemorrhage. And all the platelet counts usually remain in the normal range. During pregnancy, pregnant patients often have mildly decreased platelet counts, a condition known as gestational thrombocytopenia. And most hepatic enzymes, including the transaminases, they remain within normal range in pregnancy. So normal adaptations to pregnancy include increase in GFR, renal blood flow, renal basement membrane permeability, which causes a decrease in serum blood urea, nitrogen, and creatinine, and an increase in urinary protein excretion. So in normal people, more than 150 milligrams of protein in renal excretion is abnormal, but in pregnants 150 to 300 would be normal. If it is more than 300 milligrams of protein, then that would be abnormal. Okay, and then we have another question related to what we have read. 33-year-old woman gravida 2 para 1 comes to the clinic for a routine prenatal visit at 26 weeks gestation. Her pregnancy has been uncomplicated. BMI is 23. Laboratory test shows hematocrit is 34. Hepatitis B surface antigen is negative, HIV negative, rapid plasma reagent negative, not detected, ABO-A positive, antibody screen negative, urine culture negative, chlamydia is negative. An ultrasound at 20 weeks gestation showed an anterior placenta and normal fetal anatomy. Patient's only concern today is a lower leg swelling and occurs after prolonged standing but resolves when sitting or lying down. Her last pregnancy was complicated by group B streptococcus colonization requiring prophylaxis during the delivery. The patient has no chronic medical conditions and takes only prenatal vitamins. She is a radiologist, now uses tobacco, alcohol or drugs. Blood pressure is 135/80, pulse is 65. Physical examination show minimal pedal edema and negative human sign. Fundal height is 27. Okay, and the gestational age is 26. Fetal heart rate is 140. Which of the following tests should be obtained in this visit? So she's here around 26 weeks of gestation, right? 24-hour urine protein collection, chlamydia trachomatis, cervical PCR, clean catch urine, GBS, Hep B surface antigen, oral glucose. Okay, so Hep B surface antigen and our chlamydia, it has been done in the first initial visit, which was negative. We can repeat it in the third trimester if there is any high risk behavior. So these options would be answered as Hep B surface antigen, chlamydia is done at the initial visit and repeated during the third trimester in only high-risk patients like IV drug use or STI early in pregnancy. So these two are out of the options. Then we have clean catch urine. 24-hour urine protein collection is the gold standard to do if we have any suspect if we suspect preeclampsia, but her blood pressure is normal, right? And there is no other signs of preeclampsia. We do have some complaints regarding leg swelling, but this much leg swelling is normal. It is minimal pedal edema, so that is physiological adaptation of a mommy's body for the child, right? So we are not going to do this. Clean catch urine culture has already been obtained, and then we have options: group B streptococcus rectovaginal culture and oral glucose challenge test. And we read that there was in the previous pregnancy group B streptococcus colonization was there and they required prophylaxis. We would think that we have to do this now, but group B streptococcus rectovaginal culture is obtained 35 weeks onwards, 35 to 37 weeks. So right now the gestational age is 26 weeks, and we do have oral glucose challenge test, which is done from 24 to 28 weeks. So we are going to go for oral glucose challenge test. Initial prenatal visit would include all of these, which we read in Toronto notes. 24 to 28 weeks, we go for antibody screen, if RHD negative, and we go for the glucose challenge test. And 35 to 37 weeks, we go for GBS culture. Just a quick read to these two paragraphs. During the second and third trimesters of pregnancy, placenta secretes hormone that increases maternal. Placenta would secrete such hormones that increases maternal insulin resistance to promote fetal growth and metabolism. Women with inadequate pancreatic function to overcome insulin resistance are at a risk of developing GDM. Risk factors for GDM include obesity, excessive weight gain during pregnancy, family history of diabetes, previous macrosomic infant. Uncontrolled hyperglycemic is dangerous to both the mother and fetus, with complications such as miscarriage, birth defects, fetal macrosomia, preeclampsia. So uncontrolled hyperglycemia can cause miscarriage, birth defects, macrosomia, and preeclampsia. Women are at high risk of undiagnosed type 2 diabetes mellitus should undergo screening during their initial prenatal visit. So not around 35 to 37 weeks, but in their initial prenatal visit, we are going to check for hemoglobin A1C or glucose tolerant test who are at risk of a diagnosis of diabetes. All other patients should undergo an oral glucose challenge test at the end of the second trimester, 24 to 28 weeks. Most common approach consists of screening with 1 hour 50 grams GCT followed by confirmation with a 3 hour 100 grams GTT. And we read that urine culture is obtained in the initial visit. We just have to look for any asymptomatic bacteriuria. We have to treat it because of the increased risk of ascending infection. We read that GBS is in 35 to 37 weeks, so we are going to go for, as in second and third trimester, placental hormones can increase maternal insulin resistance, which would lead to maternal hyperglycemia. So we have to screen all of the women at 24 to 28 weeks gestation for gestational diabetes mellitus. That is routine screening. That's all. Thank you.